double down on our efforts to catch up with science and technology and innovation. Science and technology and innovation, these are indispensable in the modern economy, in the modern world.
The problem being that, while we have our PhDs here, there aren't enough of us. And everywhere else in the world, for research to be successful, you need a complete research group.
It's very important that the PAASE members and scientists based in the Philippines are continuously in contact, so we will know the needs of the Filipinos and opportunities that the Filipinos can have to do science with their PAASE counterparts.
I think that is one of the good programs that they keep on supporting some of the initiatives of our researchers and scientists here in the country.
The role of this cooperation among these government agencies really is to be able to attract science and technology global-based companies to set up shop here. And that is really key in terms of developing the science and technology innovation ecosystem in the country.
We really need to ratchet up the appreciation, the recognition of the importance of science and technology and innovation.
And we are all trying to attain what we call the common good, the greater, higher, long-term good of the Filipino people. Good morning, everyone. Giselle Concepcion here, PAASE President. I'm very pleased and honored to host PAASE Fireside Chats Episode 2, The Science of Emergency Care, with my co-host, Dr. Michael T., who is Professor of the Department of Physiology of the UP College of Medicine and also Vice Chancellor for Planning and Development of UP Manila. Today, we have a very important topic with, I would say, heroic, patriotic MDs as our speakers. And as you know, PAASE is committed to sharing with the audience during this live event and also on our website with the recordings of our events, relevant SNT-based issues that persist in our society today. In this time of COVID, we know that there are a lot of emergencies and urgencies, but little do we appreciate that even without COVID, there are such emergencies. So today, I will be introducing our first speaker with whom I conceptualized this fireside chat. And then Dr. Michael T. will introduce the second and third speakers, after which we will have our open forum and Q&A. This first speaker is someone who's very special to me because he was my student in organic chemistry, which tells you that I am much older than him. He's also very special because he is a descendant of our national hero, Jose Rizal. This is none other than Dr. Teodoro Teddy Herbosa. He is Associate Professor of Emergency Medicine at the College of Medicine of UP Manila, and he was Executive Vice President of the University of the Philippines System from 2017 and 2021 to 2021. as we are told, Ted is now on his mission to establish vaccination in Baguio. So he is traveling, and he's just telling you that he's a non-stop action person, as he was in the DOH when he was undersecretary, and now as the convener of health emergency group in the UP Manila National Institute of Health. So may I now turn over the floor to Dr. Ted Herbosa and tell us a little bit more about your designations and affiliations. Thank you.
Thank you very much, Giselle, and thank you for the kind invitation. Allow me to share my screen, no? Well, it's not sharing.
Okay, we have to.
Wait, you have to allow me to share, I think.
Yes, just a moment.
Yeah, so it's not. So anyway, thank you for this kind of invitation and the idea of PAASE Fireside Chat discussing emergency care in the Philippines. So my first task is to give you an overview of what emergency care is like in the Philippines compared to the other countries where I trained. Ayaw pa rin mag-screen share. You have to make me co-host or
Sir,
something.
co-host na po kayo, sir. And
But ayaw.
turned
let
on
me
na rin
check,
po yung multiple participants can share.
Multiple participants.
Apo, naka-turn on na rin po.
Screen, broadcast, start broadcast. Okay, sorry. Yan, there. Sorry.
It worked earlier. Oh.
So now, so how do I go to my slides? Sorry, so I'm using a phone, not a laptop, so it's a bit more challenging.
That's okay.
There you go. Okay. So, yan. Let me go to my title. So I decided to give a bit of history of what the Philippine emergency medicine coverage was like. No? So of course, I did all this program of emergency medicine at the largest university hospital in the Philippines, the Philippine General Hospital, with a nice photo here. This is a mural in the lobby of the Philippine General Hospital, and it actually talks about look at this. This is about healthcare. They're treating someone and they're using herbal medicine all the way back. Now, the interesting thing about medicine in the Philippines was we've got one of the oldest academic institutions in this country, established in 1611, the University of Santo Tomas. And by 1870, it had established its own faculty of medicine and surgery, where in 1870 they had their first 12 graduates of medicine. We also have a very old hospital, San Lazaro Hospital, which is a military hospital of the Spanish, established in 1577, and another hospital, San Juan de Dios Hospital, established in 1578. The interesting thing is all three of these hospitals are still functional today, and the major hospitals. And then the Spanish era came. By 1902, they established, the Americans were here, and they established the Philippine Medical School in 1905. The Philippine Medical School is the precursor of the UP College of Medicine. The Philippine General Hospital was built beside it so that it could be a teaching hospital. So they patterned it after the concept then at that time, very new concept of university hospitals, patterned after the Johns Hopkins University in the United States. So this is how Philippine General Hospital looked like. It was supposed to be a center of tropical medicine. The interesting thing is UP was established in 1908, but by 1909 we had a graduation. And the first batch of graduates of the University of the Philippines actually came from the College of Medicine, which was previously the Philippine Medical School. So you see here the list of the first 8 doctors graduated by the University of the Philippines. This is the pre-hospital care then. Horse-drawn carriages brought especially similar to what Napoleon Bonaparte used in the 1700s, wherein they brought 6 soldiers. And actually the father of emergency medicine is the Surgeon General of Napoleon Bonaparte. Also in that early American era, we had epidemics worse than the pandemic that we're suffering today, because over 200,000 actually died. And at that time, there was a fight between the American public health doctors and the local doctors, because the local doctors wanted to honor the tradition of burol or wakes, but the Americans wanted the dead people who died from cholera cremated. So there was a big cultural clash, and today we actually address this now with what we call social determinants in healthcare. Then World War II came. Philippine General Hospital still continued to be a casualty zone. The Japanese eventually took over it, but at that time, the U.S. military were the one providing care to those in the wounded era. So after Manila was liberated, we ushered in what I would call the golden age of Philippine medicine. This was in the 50s, in the 60s, and sorry, lumalabas yung aking messages. And this was the 50s and the 60s, and we started to modernize public hospitals in the Philippines. And we even had a first kidney transplant in the late 50s and open heart surgery in the 60s at the Philippine General Hospital. And also in the early 60s, we started to have the proliferation of modern private hospitals, Makati Medical Center, Manila, Riverside in Bacolod, etc. But 60s was also the time that America started to build their hospital and healthcare system. So that's the time they wanted to hire many doctors and nurses. And we saw an exodus of our healthcare professionals being brought to the US, which continues up to today. I think this continued on in the 70s during the time of martial law, wherein doctors that were opposed to President Marcos decided to just flee and move to America. Now, emergency medicine in the Philippines at that time, of course, was part of all hospitals built by the Americans. And they identified a person called an ambulance surgeon who took care of pre-hospital care and the ambulances. But by the 1950s and the 70s, we borrowed the residency program. And we assigned junior doctors or interns or junior residents as part of their medical education in the emergency department. And these were specialties, young doctors training in surgery, medicine, pediatrics, OB-GYN. So this was how the first, I would think this is one of the oldest ambulances in the Philippines. I think that picture was about 1910. So again, in the early 50s, there was no doctor. Doctors that reported to the ER reported to different departments: medicine, surgery, obstetrics, pediatrics. There were no specific specialty of emergency medicine physician. It was only in the 1970s that the late Dr. Arcardo, together with several other specialists, developed a specialty called the Department of Family Medicine. So they were identifying and toying of diverting it into two: community medicine and emergency medicine. And at that time, the emergency room complex, which is how it was named, was assigned to the Department of Family Medicine to administer and run. Later on in 1986, when I was a second-year resident in surgery, the Philippines had its first board-certified emergency physician from the United States. His name is Dr. Joel Gernsheimer. He was married to a Filipina, and the Filipina was a graduate who had to do the 2-year return to get from a J1 visa after residency training in the US. So Joel, during that 2 years, went with his wife, a Filipina, and he got a job as an emergency physician in the Department of Family Medicine. And I was a young resident then. So I had a lot of discussions with him, and he introduced me to the field of emergency medicine and how aggressive he was in treating the poor patients in PGH. Now, the real prime mover of emergency care in the university was the late Dr. Antonio Montalban. He was then deputy director when we created the Philippine Society of Emergency Care Physicians. So he consolidated and grouped all the different specialties who were interested in emergency care. Dr. Montalban was a pediatric orthopedic surgeon that trained in the UK. So he saw the UK version, which was the accident and emergency physician. So in 1989, we established the Philippine Society of Emergency Care Physicians. I was a young resident then, and we started to establish, like PAASE, several meetings and postgraduate courses. And we even published a journal because Dr. Montalban was very much interested in academic research and publication. So the national organization had over 200 members, and we were doing twice big conferences plus monthly conferences as we brought different specialists to different areas to try and see how rural medicine or medicine was practiced in other parts of the Philippines. By 1990, the then director of the hospital appointed Dr. Richard Chonko. They departmentalized the department of before it was an emergency room complex with different departments administered by Family Med. They created finally a department of emergency medical services. That's why the old name of the Department of Emergency Medicine was DEMS, which is Emergency Medical Services. And this was created by an act of the UP Board of and eventually I'm the second chair because when Dr. Chonko stepped down, I was appointed by Dr. Montalban to be the chair. Also around that time, there was a young third-year medical student that did an international rotation, and we were able to write a paper. The professor of this young girl, Dr. Lynn Palacod, who was a Filipino descent, was actually Professor Peter Rosen, who was the author of the textbook on emergency medicine. So this is the late Peter Rosen, and because of that connection, I decided to visit Dr. Rosen at the University of Southern California, San Diego. And I realized he was a surgeon like me. He trained as a surgeon, but then he pioneered in the specialty of emergency medicine in the US. They got it approved as a recognized specialty of the American Medical Association, and eventually pushed me to also develop EM in the Philippines. So this was my first faculty. The colored pictures, the two ladies are real emergency physicians. The rest are orthopedic surgeons, pulmonologists, toxicologists, trauma surgeon. And the two are trained from the US. Dr. Wilma Geck, trained in emergency medicine in the US, graduated from UE. And Dr. Ria Ribaya, who also trained as a pediatric emergency medicine. These are my first four graduates in 1999. And the chief residents at that time were Dr. Limhenko and Dr. Regudo. Both of them have moved to Australia because by the time I graduated, Australia was hiring lots of emergency physicians. And of course, the two couldn't resist the opportunity. And they are still there doing very well. They're both now certified as well in the Australian Association of Emergency Medicine. Richard Dimagiba is now the vice chair, and Mia Tapunyar is in the administration of the Philippine General Hospital. So we did lots of engagements with the airport, with drills, with young doctors, trying to teach them the modern concepts of emergency care. We did a lot of simulation. During my term, we were running the advanced life support courses, the basic life support courses, as we had all the mannequins necessary to do simulation education. Over on the other side of the Pasig River, we also had a private group, which was the Makati Medical Center, that developed emergency medicine as well. I think that was for better quality care of the private patients, and because of the developments in the US. So they developed the Philippine College of Emergency Physicians initially, which eventually changed the name to Philippine College of Emergency Medicine and Acute Care, or PCMAC. Now, all of us eventually were working together. Some of the graduates of PCMAC were doing to the other hospitals in Makati, Hospital ng Makati, San Juan de Dios. While my graduates were going to Manila Doctors, Medical City, Asian Hospital, East Avenue. And we grew from there. So we grew from there, and residency programs in about 20, I think about more over 20 hospitals now have residency programs in emergency medicine. After my term as chair, I was invited to be a visiting professor at the University of Kebangsaan, Malaysia. And it's very interesting. We did a lot of simulation studies there as well, and was able to help develop emergency medicine graduates as well in Malaysia. So I always, when international meetings, I would introduce my graduates in Malaysia, meet your cousins in the Philippines. The interesting thing is when PCMAC and PSECP was formed, they didn't want to join each other because there was some professional brouhaha that happened sometime during the founding. we were able to fix that. In 2010, in May 18, 2010, we, the next generation of leaders in emergency medicine, decided to dissolve the two organizations. PCMAC and PSECP was dissolved, and we created a new one called the Philippine College of Emergency Medicine. And that, I think, pushed the growth of the College of Emergency Medicine even bigger. So we had big conferences. We included nurses, paramedics, ambulance crew to all our conferences. So it was all the team effort of emergency care. Now, let's talk about science and how it has affected emergency care. And I'll start with a quote from Clifford Stoll. Data is not information. Information is not knowledge. Knowledge is not understanding. And understanding is not wisdom. So in emergency care, we save lives. And we need a lot of wisdom to save lives. Now, one of the crossroads between EM is it was the most digital. In fact, in the US, it was the first one that embraced electronic medical records. And truly, today, as we use telehealth now more often, I think it's very important to realize that COVID-19 pushed the telehealth agenda so much faster. So as what Seema Verma said, I think the genie is out of the bottle in this one. So we can't return. People now want to consult a doctor, they do a telemedicine consult or a telehealth consult. So in terms of pre-hospital care, this digital invasion of practice also heightened the care because we are a time-critical specialty. You need to act fast. You need to decide fast with little data and little information, and a lot of wisdom is needed to actually save lives. So we are beginning to use in trauma the concepts of pre-hospital care. In stroke, they're using robotics and telehealth. So, for example, there was this previous story before where
As we said, Ted is traveling, so he may have.
because it's all.
We're losing you, Ted. We're losing you. Well, Michael, I think Ted must have reached a spot where the signal is very weak.
Yeah, I think that's what happened, ma'am. Maybe we can. You think we can proceed with the next speaker, and then
I would
let's,
think so. We'll just get Ted to continue later. All
yes,
right?
ma'am. So yes, I agree, ma'am.
Sige. So perhaps you can
So,
now.
I think I'm
good
muted.
morning,
Hello?
everyone.
Okay. I got
Okay,
muted.
excuse me.
Yes, sir.
Are you
Go ahead,
back?
sir.
Go ahead
Oh,
then.
wait. Sorry. So
Lost your slides also.
I don't know. I got accidentally muted.
Oh,
Start broadcast. What happened?
all right. We'll wait.
Wait lang. So is it broadcasting already? Not yet. There you go.
There now.
Okay.
About to.
Okay. So I'm sorry I got muted. I didn't realize I was muted. No wonder there was someone talking. So anyway, the other place where science is really intervening is in my field of interest, which is disaster risk reduction. And but what is important is disaster risk reduction research is more complex. The same way emergency medicine, pre-hospital care is complex. It's very important to have an actual framework. So we've included disaster research in the DOST agenda, but we're doing a DRR framework approach so that the the studies can be done and be consolidated. So that's actually an important part of how to push the research in the DRR. So we're really pushing, my pitch really is for more research and innovation in the field of emergency medicine, trying to get more funds with the help of multidisciplinary studies in EM research. We would be willing and happy to standardize the frameworks. You need to work with the specialists in the field, the end users of all the technology and innovation we will develop. And we will apply this with the lessons in really saving lives, and then really publish and share this information to the rest of the world. So very important, my last slides are really all about making sure that this talk, this fireside chat will end up with some sort of discussion with the other disciplines to really understand emergency medicine and its development, the importance of evidence-based policies as we develop it now. In IT governance, we talk about EDM, or evaluate, direct, and monitor. You ensure a governance framework of the agenda, and then you direct it so that you will have benefits for all the stakeholders, and even manage or optimize the risk and the resources, and then also monitor the progress. So I'll end with my last slide. No? The last slide is a quote from Confucius, and I quote, "There are three paths to wisdom. First is by reflection, which is the noblest. Second is by imitation, which is the easiest. And third is by experience, which is the bitterest." Thank you very much, everyone. I do hope I have explained the story of emergency medicine in the Philippines.
Thank you so much, Ted, for your insights and for recognizing or recounting the history of emergency medicine development in the Philippines. So you will stay around for our other talks and our discussion later, right? So
Yes, I will.
Okay, at this point, Dr. Michael T. will introduce our second speaker.
Thank you, Professor Concepcion, and thank you, Professor Ted Herbosa, for that introduction of how the emergency medicine developed in the Philippines. You are really the pioneer that I recognize here, aside from Dr. Montalban, because I was a student when that was happening, and you actually recruited my classmate who's going to speak later on about emergency medicine. Our next speaker is Dr. Pauline Convocar. She is the immediate past president of the Philippine College of Emergency Medicine, and she now leads the PCEM's section on advocacy in addressing national and global emergency care disparity issues and in developing inclusive healthcare system for the disadvantaged. She has organized the section on gender equity and empowerment to ensure inclusivity and diversity in the field of emergency medicine. She is currently the board member of the Asian Society of Emergency Medicine and a member of the International Federation of Emergency Medicine's Research and Core Curriculum and Education Committees. With kindred spirit, she has established pioneering emergency medicine residency programs in the Philippines. So with that, I'd like to now give the floor, our virtual floor, to Dr. Pauline Convocar. Pauline, please.
Magandang umaga. Salamat, Sir Mike, for the kind introduction. Just give me a moment, please, to share my screen. Kindly confirm if you're now seeing my screen and you can hear me.
I can hear you and I can see the screen. Thank you.
Thank you very much. Maayong aga, maayong udto, gabi. Good morning, good afternoon, or good evening, wherever your time zone may be. I would like to thank, of course, the Philippine American Academy of Science and Engineering for the opportunity to share with you our discipline. So we are the frontliners, emergency medicine. But just short shout out to my fans from Davao and Bacolod, and of course here in Manila. Good morning. I'm very happy to share with you, very humbled and honored to speak on research priorities. So speaking after Sir Ted is a daunting task because you know how Sir Ted, he never fails to amaze us with his stories. And I'm a proud anak of PGH as a trainee before. So I'm humbled and honored really to speak on now the research priorities and advocacies in emergency care. So we are witnesses to daily preventable tragedies, and we are uniquely qualified to advocate for effective measures to reduce such public health emergencies or injuries or illnesses. So for us, advocacy really comes naturally. I really do not have any disclosure for any conflicts of interest. However, I just would like to disclose that my views are presently really not representative of the Philippine College of Emergency Medicine, of which I am the immediate past president. So just to continue the story of Sir Ted, I just would like to start with sharing with what is really obvious. So where are we as the status of emergency care in the Philippines, globally or even nationally? So stating the obvious, we have really a unique geographical location as a country in the world. As you already know, we are smack right in the middle of the Pacific Ring of Fire. And as such, this made us really disaster specialties. But unfortunately, di naman tayo ginawang emergency specialists lahat. So just before COVID happened, we had this series of earthquakes in the south, volcanic eruptions, but the sad truth is that this does not make us all really experts in emergency medicine or even emergency care. So you see, there is a fine line between one just operating on our daily emergencies when we needed to do the best for each individual or beyond capacity when there is a shift of doing the greatest good for the greatest number. We needed to maximize survival in disasters when the time comes. So these are just parang a run through of the disasters that the Philippines have had experienced. So we are even parang we're tagged as disaster specialists whenever we talk in our foreign engagements. So we're really experts in this field. And unfortunately this does not really make us experts in emergency care kasi we've somehow neglected this part of the healthcare spectrum. So kasi in emergency, we wanted to really do the best for each individual. We really wanted to save individual lives. Unfortunately, when that capacity is overwhelmed, our healthcare capacity is overwhelmed, we somehow shift our focus, and then we just had to do the greatest good for the greatest number because we wanted to maximize survival. So we actually have this dictum in emergency medicine when we're challenged that we had to do the best for the most with the least by the fewest. This just means that we will have to do the best for the greatest number of people or the most number of people with the least amount of resources by the fewest number of staff. So the challenge really here, or maybe the point of discussion probably later on will be, if a hospital is unable to handle day-to-day emergencies in the emergency department, it will not be able to cope with the demands of disasters. So this actually unearthed so many things. It opened the Pandora's box when COVID happened. But as we all know, the Filipino spirit is waterproof. We make ways, we find ways. Even in the situations when there's a disparity in healthcare. So even if our healthcare workforce is very much overwhelmed, even in this rural area when the doctor really has to go off duty sometimes and be on call in emergency cases, it is very much telling of how we are as a people. We're very resilient and we really find ways to still deliver the services that are expected of us in spite of the situation. And we know also that the Philippines as an archipelago really pose challenges to us in our access to quality emergency healthcare. So especially in our geographically isolated and disadvantaged areas. And I'm one witness to this situation when I was before a DPTV, or I was a doctor to the barrio somewhere here in Surigao del Norte. In one of the small islands here, I was the lone doctor of 20,000 population back then. So I have a really soft spot for public health. And this was me with several kilograms lighter and many shades darker when I was then DPTV. So just a bit of a story why I went into emergency medicine, because I saw that emergency medicine is really the link between public health, community health, and that of the formal healthcare system. So this is not unusual, seeing patients being transported from the rurals, from being carried by hammocks, and also it is also not unusual to see a very wide disparity when you see more advanced cases of EMS models or EMS systems like this in Davao. But although there may be disparities between geographical locations, there's also specific disparity even within a specific geographical scenario. Like say, for example, in an urban setting like this is also not unusual, but we still get to see, despite the advances in EMS, we still get to see these kinds of situation when patients are being transported in jeepneys, so very substandard, in tricycles carrying their patients. And of course, you all are very familiar with the award that was just because of the documentation that was done because of this ambulansyang de PAA. So our healthcare system is really very much fragmented, and our emergency care really suffered a lot because of this. So we need to still be able to fulfill the right of the patients to access to emergency healthcare despite these challenges. So we also know that our healthcare system is dichotomized into the public health and private health system. And we see every day that there is disparity and access blocks in capacities of our patients to pay and their preferences. And we also know the long time, if I may say, neglect of our healthcare system, our public health system, because of really shortages in staff, shortages in resources. So we really had to, it was really unearthed, it was really focused and highlighted during the pandemic. So you see, when a patient presents at the ED or the emergency department, you're not seeing just one sick patient. In truth, you're seeing the situations. You're seeing a sick person, which may be inappropriately brought to the ED because the patient may be a non-emergency or a really true emergency, but there's no more bed for the patient. So it is a true emergency, but there's access block. But then again, it is not just the individual. You're also seeing a very sick health system. So this is what we just wanted to also present to this forum, that we're not just looking at the ED as looking after individual patients. We're looking really at an entirety or the whole spectrum of care. And they all end up at the emergency department all seeking for care. So this is pre-pandemic, and you already have this congestion issue, and the demand changes when disaster strikes. So this is an example of hospitals that still need to continue their services despite being victims themselves. So the situation changes, the demand and utilization of our EDs changes during surge, be it a natural disaster, a social disaster, an infectious disease disaster. It takes a natural disaster actually to really reveal that there is a social disaster. So if you notice, it was the same picture of the same spot, and this is post-pandemic. This is pandemic time, this is COVID time. It is the same thing. And you're just seeing here still a congested ED with nowhere to go. There's access block on the side of the patients being admitted on the floors, and their people are still coming in. So what we do is we tend to be like very elastic and very flexible. We expand and we expand and we expand. But there is such a thing as a breaking point. So we all know of the story of emergency departments closing down, but technically we really do not close down because we still accept patients that are imminent, arrested. So the burden of still providing emergency care is still on the emergency department and on the emergency physician. It's our moral duty to still care for emergencies despite allegedly having to close down our EDs. So from what I usually say when I'm asked, please don't trust us that much because we may be expandable, but don't trust us too much. Don't stretch us too far. We also have a breaking point. So this is what I always say, because no emergency physician, whenever you'll ask, probably no emergency physician will admit that hindi na kinaya o hindi na kinakaya. It's always kakayanin. So it's always like that. It's the attitude also that despite everything, sobrang ng burnout, people will still go on, continue to go on duty every day because I think it's a special kind of it's really a unique kind of discipline that we really cannot we may turn away patients because of maximizing survival or doing something for the greatest number of people. But at the end of the day, you still have to really continue serving people, serving the really emergent or the critically ill patients. So the EDs have been bearing the brunt of a sick health system for a long time, because inherently we can really declare that this is already a disaster and we have reached our emergency mode or a crisis mode. But we really have to also understand that for a long time, have we been operating at our near critical levels. So that's why we were also have been parang immune or desensitized to the fact that we've been operating at near disaster levels even before the pandemic. So that's a point to ponder as well. And we all know that mahaba-habang usapan pa ito, we are really running the marathon with frequently changing rules. So we have to understand that we really need to protect now the last line, the frontliners of the frontliners, but we also need to also strengthen the community or the community health, the referral networks, because we need to also strengthen the first line and be able to, for the patients to be able to be brought to the appropriate facilities. So we now realize that there is really an indispensable role of emergency medicine in now high consequence infectious diseases. So this was presented, published in 27 of 2020, February 27 of 2020, and this was just the start of the pandemic. And with the current outbreak, the time has come to put emergency medicine at the forefront of public health. We cannot stay in our silos. We cannot stay within the bounds of our room, but we need to also empower all of our healthcare professionals outside of our so-called comfort spot. So I'd like to change and challenge our perspectives. We all really just call our ER as ER, but it really is not just a room. There's just so many rooms in our ER, and there's so many services that are, and so many activities that are going in our emergency department. So challenging everybody to change our perspectives. It is not just a room, it is a department. Transitioning even to have an academic arm, we're training people, we're educating people. So it's actually really an academic department of emergency medicine. And it was not presented by Sir Ted, but it is really seen as a part of an emergency care spectrum. So it is really an emergency care spectrum. It's not just confined in your ER or in your ED. So this is what I'm saying. We are here. This is the emergency unit. You may see this as a very small unit, but it actually is a very wide spectrum. Our care, emergency care, transcends the boundaries of the EU. It transcends beyond even to include the pre-hospital part. And care is being continued and still seamless from the time the patient was seen at home, at work, wherever the incident happens, or whenever the injury or the illness happens. Supposedly and ideally, this patient should have been fetched from home, brought to the ED, the nearest facility, the most appropriate, and given the definitive care. Now, there's only 3 dispositions for emergency care. We really need to admit the patient if needed, or if your hospital is not capable or do not have the resources for care for such particular case, then we may transfer that patient to another facility. Or if you were able to address the problem of that patient and manage the patient and the patient improve, then you may discharge the patient from the ED. So see, we do not really become primary care providers for our patients. We are an acute and emergency care discipline. So it is really you may see it as a small subset of an entire healthcare service, but it is very crucial, or the best or the worst 15 minutes of your lives. So nandito lahat yon sa emergency unit, and everything else, all actions are here in the emergency unit. So that is the reason why we really need to strengthen also our referral systems, because kung hindi capable yung unit na yon, then we need to transfer the patient to the more appropriate unit or the more capable unit to address the problem. So emergency problems or ED problems are not just ED problems, they're really system problems. And the approach should really be systemic thinking, systemic issues and systemic solutions. But we also need to be systematic about it. We need to have standards, we need to be consistent, we need to have methods. But with limited resources, we also need to be strategic about it. So we need to really focus on some of those who really just have, it should be purposive, it should be very efficient with our limited resources. So moving on to the priorities now. So the Philippine emergency care system actually is a very young specialty, as what was stated by Sir Ted. And as a very young discipline, these are our core values. Sorry. Just very quickly. So these are our core values, but we're just actually 19 institutions all over the Philippines. So we started here in Metro Manila, but then we already spread across the country. We have now one training institution in Davao, that's Southern Philippines Medical Center. And as I've said, this is Bacolod. Both are DOH hospitals. We have one in Cebu, one in Tacloban, and one in Pampanga. So those are the non-Manila based training institutions. But unfortunately, sobrang urban-centric pa rin si emergency medicine. There are currently only around 450 of us certified in the Philippines. So that would actually be just around one certified EM for every 360 Filipinos. And most of our graduates are actually not that active. Some of our graduates are really not that active. And even our active EM physicians are not here in the Philippines. So about research in the low resource setting, much have been changed during COVID. So if you notice here, this is an example of a research that I just checked in the PubMed portal, that there's this, for a 5-year period, there was really steady rise in the number of researches for hypertension. But contrast that to COVID, and you see an explosion of researches done, which is translated to one research in every 5 minutes. Even if emergency medicine also have researches across 5 years, but it is relatively still slow, with a peak of researches done together with that of, or I mean parallel to that of COVID. So somehow, they've realized the importance of emergency care systems when the pandemic happens. Just as what I've said, it has really opened the Pandora's box of looking at it in an entire spectrum of care. So actually, the lethal impact of medical emergencies worldwide is that it is found to be 4 to 5 times higher in low or middle income countries around the world, just like the Philippines, in cases of their mortality burden of medical emergencies. And just imagine, we don't have data to show the full impact of burden of emergency medical diseases in the Philippines. So we don't have data for this. We just know that people go to the ED, but more so they're computed, or like they're put in statistics for some other diseases like chronic diseases, but there are no data specific for emergency care, for the acute care or emergency care for that specific chronic disease. So there's really this research gap. And furthermore, the Global Forum for Health Research even has this 1090 gap, where 10% of the resources are spent every year for health research, and these are used for health problems in low resource countries, where over 90% of all preventable deaths worldwide could have been prevented. So we really need to close that gap. So we should know that health research should not only generate knowledge, it should also lead to action. So we really wanted translational researches, transformational researches, and we need to do this with research outcomes that need to guide our policy and program development. So we need to have healthcare interventions that should be evidence-based and grounded in solid research. So these are just 5 of the generic areas of research that was presented in that Global Forum for Health Research. But I'd like to show you the other specific emergency care research priorities in one of the prioritization activities that we've done in World Health, with World Health. So this is harnessing interdisciplinary collaboration to improve emergency care in LMICs, which was a result of research prioritization setting exercises. This was done sometime January in 2019. So for a group of 16 emergency care experts. So the process was that it is a 4-step process: identifying the problem, identifying the research questions, putting it in context as well as that of the what challenges and capacity of the countries that are among the low resource setting scenarios, and then of course now the research prioritization and ranking. And these are the results. So for the 7 highest ranking research questions, the first really is that there should be emergency care system indicators. The question was, what are the best quality and access indicators for emergency care in LMICs that engage the different stakeholders? So we really lack this. We need to engage the community, our patients, the providers, and even our policymakers. So even costing for PhilHealth, we cannot provide because we do not have data. So these are the things that we need to do. We may have systematic reviews of some emergency care quality and safety indicators. We may focus on number of metrics because we really have limited data on that. And then focus also on outcomes rather than just the process or structures of care. The second thing that was a priority in that activity is the barriers to care. So how will we describe the journey of a patient through emergency care system in order to identify barriers to care? This includes differentials imposed by income, geography, and discrimination. So these really are actually access blocks. What makes our patients choose a particular hospital over another? If you'll ask, probably the answer is really about financial constraints. So we need to also have researches on the barriers to care, which may include not just finances, but maybe also culture, infrastructure, just like our GDAC areas or GDAS, communication and coordination problems, transport, equipment, and of course, staff. If the hospital or the facility is not capable, we need to transfer the patient. That's another barrier to care. So we need to empower or capacitate all our health facilities in our healthcare delivery network. Third is registries. We lack registries. We cannot improve what we cannot measure. So we do not have baselines. We have difficulty putting national registries. These have been identified as some of the obstacles. So we need to standardize such registries. Examples, just some of the examples include trauma, stroke, heart attack, resuscitation. So we need to improve them and include pre-hospital and facility settings. So we sometimes are very hospital-centric. We only measure data in hospital and in facility. We forget that there's an entire world out there, even before the patient reaches the hospital. We have already, care is already initiated. Very important thing also is triage. Questions may be where triage systems are existent. What is the accuracy of the triage system? If they do not exist, what are the barriers why it is not implemented? And what are the effects on triage of triage on patient outcomes and emergency system workload? So these are also some of the things that we need to address. And in truth, we really do not have a national triage system that is standardized across the country. We have different triage systems even among our training institutions with EM training programs. So we need to have this to predict clinical outcomes, to have a similar language or to have one language as to what kind of patient are we seeing, what's the acuity, what's the severity. So when we transfer patients, we all understand that this patient needs this kind of care. Second to the last, third from the last is patient characteristics. We do not have also particular profiling of our case mix. So we need to understand also our case mix and patient's characteristics so that we may also adapt our services, add more to our services if that's the particular profile of the patients that we're seeing. So we need to better describe disease profiles, who seek emergency care, why they seek care, why they do not seek care. And this will really impact on the outcomes of our patients, including our mortality rates. Staffing has been a problem even before the pandemic. So how can countries meet the adequate staffing for emergency care delivery? There has been much debate about the doctor is to patient ratio in the ED, nurse is to patient ratio in the ED. We need to address these things because we need to also address issues of retention, burnout, and of course our staff safety. So shortages in healthcare staff, but the lack of specialty trained or skilled personnel in emergency care is also a particular challenge. So it's not just about the number, it's also about the competency of the staff to attend to patients in the emergency department. Lastly is, of course, cost effectiveness. Cost effectiveness as delivered across the health system, which includes now pre-hospital care, emergency unit, inpatient, and critical care settings. For now, as of present, PhilHealth does not include pre-hospital in the costing of all the case rates. And they also have very minimal case rates for specific emergency care services. So we need to also look into that part. So in the context of resource constraints common to virtually all healthcare systems across all countries, bilang Pilipinas, it is very important that we need to address cost effectiveness of our interventions and our services. So moving on to the last few slides, since we are natural advocates of public health and emergency care, we need to understand that there is an increasing role really of emergency medicine as it stands in the intersection between public health, public safety, and healthcare. So hindi pwedeng ihiwalay or totally put or separate emergency care and not care about the other aspects of healthcare, even back to the recovery or even to the rehabilitative part of care for our patients. So we really need to look at it as an entirety, as part of the spectrum. Emergency departments are 24/7 open 24/7, so they're naturally partners of public health. In actuality, we've been very vocal about our role and our position pre-pandemic as part of nation building through our emergency medicine advocacies. And if you notice in our several programs, training programs, we've already established and promoted EM as really the link to for the hospitals or the communities or for public health. So the Philippines is actually only one country that has made its emergency care system assessment tool. Assessment as a country. So this is a tool by the World Health Organization, and we did this again just barely a few months before the first case of COVID arrived in the Philippines. So we had this, and here we were able to identify key strategic action priorities, of which we may also be able to generate research questions or research areas. So here are just some examples of the many that were identified as key strategic action priorities. So it was identified that we needed to have a dedicated lead government office at the national level. Some countries have a dedicated emergency care bureau. It's different from HEMB or what is currently the Health Emergencies Management Bureau. It's totally different. It is for our daily emergencies and not just for pre-disasters. So it was identified that we need to have a directorate specific for emergency care under our Department of Health. Of course, we need to revisit our legislative framework. There's just so many there that we need to revisit and we need to prioritize. We are advocates for emergency medical services systems bill, because not all LGUs or local government units do have that. We need to identify and address gaps in all relevant emergency care legislative framework as well. And we do not have actually a Good Samaritan law, which is prohibitive when someone is in an emergency. They may be hesitant to respond, or they may be hesitant to help because of fear of litigation when they attend to that patient or to that victim. So these are some other key strategic action priorities that were identified, but I will not go through that one by one. But needless to say, we all need to have one language, one standard for all of our emergency care. Here also, it was stated that we need to set national response time targets. So I just would like to also inform the body, this group, that actually we are with the Department of Health with creating an ED manual. We're about to release that sometime next month for the ED management for the country or for the Philippines. We need to have also, because we have to understand that the ED is also about team approach. It's not just about doctors. We need to also develop our nurses, develop their training. Hindi porke gumraduate ng nursing and they can immediately go to the ED and care for the patient. They need to have trainings as well. For these last few slides are just pictures of some of our collaborations. This is when we talked with, we worked with the Philippine Heart Association developing an app for, and also as a navigation tool. If a patient has a heart attack, they may immediately be able to look at the GPS on where to go to their spoke before they go to the center or they go to the hub for definitive care for heart attack. So this is one of our meetings, a picture of one of our meetings when we talked to Philat about the case rates, and some of the other case rates that were being discussed are our resuscitation package, the stroke packages. Since it is a spectrum, we also work with the PNP, with all the other NGOs with regards violence and injury prevention program. And this one particularly is about drowning. So about research in the Philippines, it can never be overemphasized that we really need data. Data is not, as what was said by Sir Ted previously, data is not information. It needs to be transformed to each of the level before it becomes knowledge. So we really need translational and transformational research in emergency care. Unfortunately, our National Unified Health Research Agenda is about to end in 2022 next year. So we need to revisit that and probably include now emergency care here. There may be 6 themes in the research agenda, and we may argue that emergency care may be inserted in any of this, but I think it's high time that we need to pandemic-proof and future-proof our emergency care and prevent all situations to become a disaster or to prevent our healthcare system to be overwhelmed. So this is our journal, and these are some of our collaborations. We have our Pan-Asian Trauma Outcome Study. We have our Pan-Asian Resuscitation Outcome Study. This is one picture where we went to the Senate and the Congress to advocate for the Senate bill, the EMSS. And we wanted to professionalize our EMS professionals and our EM nursing. We were some of those, so we were one of those who developed the One Hospital Command in its draft stage, its draft phase. We wanted to have just one number to remember, because if you notice here, there's just so many numbers to remember. So our advocacy is also to have one genuine number to call in the event of an emergency. So the last messages, perhaps, we wanted to strengthen emergency care because we are the first point of contact with the health system for so much of the world, and to support the development of quality, timely emergency care that is accessible to all. So simply put, everyone has the right to emergency care. And actually, we are really an integral part of universal health care. We are first contact care, we are comprehensive care, we do extended gatekeeping, we are temporary primary care coordinator for emergencies across all spectrum or continuum of care. So these are all part of how universal health care is defined. So no patient should be refused emergency care, and it should be free at the point of contact. But more than the message, we need to target the appropriate audience. The challenges in delivering the messages, however, still exist. So we need your help. As a summary, we need to have evidence to policy and practice stance, which is crucial for effective development of emergency care systems in low resource settings, specifically for us in the Philippines. We need to close the gap. We need to build research capacity that interventions to improve ECS will be led, developed, and informed by now local researchers that are familiar with the context. We have to organize, strengthen, and have research culture. We need to find effective partners, priorities, reinforce research that address priority health needs. We need to do alignment of funders that may have the same interest in priority areas, and capacity. For standards, we need to have good research practice and norms. For translation, we need to strengthen links between policy, practice, and products of research. And we know that research informs policy and policy informs research. So unless someone like you cares a whole awful lot, nothing is going to get better. It's not from the low ranks. So thank you very much para sa Pilipinas. Thank you very much.
Maraming salamat, Dr. Pauline Podvokar. Now, before we go for the question and answer portion, let's have the third lecture. And our third lecturer is my classmate, Dr. April Llaneta. She's the current chair of the Department of Emergency Medicine at the UP College of Medicine, Philippine General Hospital, UP Manila. She's a board member of the Philippine College of Emergency Medicine. Classmate, please, thank you.
Right. Thank you, classmate. Good morning po sa lahat. Share ko lang po ang slides. Okay. So for my part po of this fireside chat, I would like to share with you our experience dealing with the COVID-19 pandemic at the emergency department of the Philippine General Hospital. So just an just an outline of my presentation. So just give an introduction, timeline of events, and then the challenges we faced and the adjustments that we had to make, and solutions and innovations. So it was in December in 2019 that the WHO informed about an outbreak of a respiratory disease in China. And in January of 2020, the WHO declared a global public health emergency of international concern. And then the following month, the disease was named. And in March, the WHO declared COVID-19 as a pandemic. And it was about the last week of March that the Philippine General Hospital was declared as one of the COVID referral centers in Metro Manila. So we needed to take a look at how we will deal with the COVID-19 as a healthcare institution and as an emergency department. So we had to prioritize the following, looking at our safety and infection control activities. Next is looking at how we will provide the services at the emergency department and in the pre-hospital care setting, since we have an emergency medical service that is manned by emergency medical technicians. So these are the people who man our ambulances and provide pre-hospital care. And we also needed to take a look at the different hospital activities and then coordinate all of this as we conduct our COVID operations. Right. So generally, we had to look at our structure, infrastructure, and our policies with regard to handling COVID-19 cases. And we also had to look at our employees, if they are properly trained, and the proper mindset, to deal with this public health emergency, so that we can provide and continue providing services, not just to the COVID-19 cases, but also to our regular patients who still will need to avail of emergency care services. So for first priority, we took a look at our safety and infection control measures. So basically, we had to divide the hospital into two, an area to manage COVID cases and an area for the non-COVID, or those who have confirmed negative for the disease. And we needed to redesign not just the entire hospital, but also the emergency department as the front line of the services to handle both COVID and non-COVID patients. So this was particularly challenging because the emergency department is operating out of a temporary location. So we are operating using an inpatient ward, as well as the corridors now around it and the hallway near one of the exits behind the main structure. So this is the emergency department when we started our COVID operations. So before, I don't know if you can imagine the emergency department of a big public hospital, dikit-dikit talaga yung patients dyan, dikit-dikit yung mga beds, congested, maraming personnel. But this part of the emergency department, we converted it to the to our COVID ED or COVID emergency department. So we needed to incorporate infection control measures, so proper spacing of the beds. Then the number of personnel is also limited, and they have to be in the highest level of PPE or personal protective equipment. And one of the most challenging of converting a regular ward, this is an open ward, is how to make sure that the air, since it's ideally, if we want to manage highly infectious cases, they would need to be in a negative pressure isolation room. Since this is the pandemic, we needed to redesign the ward and make sure that there's proper ventilation and airflow to minimize infection. So we added a lot of big industrial fans, and the windows also were redesigned so that there's a one-way flow of air out of the ward. Right, and we take a look at the ambulances, So kailangan rin sila, hindi rin mahirap maging negative pressure din ng ambulances. That would take a lot of redesigning and would be quite expensive. So the measures that the Department of Health recommended were putting a barrier, between the driver and the patient area, and also tweaking the ventilation system of the ambulances. And of course, the personnel also had to be in PPE when we're transporting COVID-confirmed patients. Right, so there are some innovations, and we are glad that our colleagues in the other specialties and other fields of science were able to come up with these innovations to help our healthcare workers and our frontliners. And they were introduced to Sanipod by the CIBOL group of Dr. Wang. And the Sanipod, it's in the picture below. This is a disinfection cubicle. So it added an additional layer of protection for our healthcare workers. So how do we use it? Before donning, so after your shift, before you don, we use the cubicle for disinfection, and then come out and then take off the PPE. So that's an added layer. So we are using, I believe, a prototype, a second generation prototype of the Sanipod, and we are looking for improvement, and maybe there will be a better or a more improved version of this that we can use, not just for this pandemic, but in the future. And then we also came across with what we call transport pods. So in this picture, this is a transport pod of the Red Cross. So this is from the Red Cross website. And we also, so I'm not sure who started or who designed the first transport pod that we are using currently. Different emergency medical services are using different designs of this transport pod. So we were given at this pandemic, one group donated a transport pod for the emergency department, so we can safely transport the patient from the emergency department to an inpatient or a ward, inpatient area. But we realized there were a lot of changes that needed to be made in the design. So right now we are not using one, but maybe others can share about the experience with the transport pod. So you put the patient inside, and that is to minimize infection. And then for us in the emergency department, because we are providing pre-hospital care, we developed or started what we call the Transfers Command Center. So this is the center that manages all the calls and those requests for patients to be transferred from one hospital to the Philippine General Hospital, being the COVID referral center. So that needed to be organized. We actually planned for a command center even before the pandemic, pero napabilis because of the pandemic. We needed to coordinate all of these transfers, and not just from one hospital to PGH, so that's what we call an inter-hospital or inter-facility transfer, but also from the community to the PGH, or from PGH back to the community or to the isolation centers and so on. So there was a lot of movement of patients, and so we focused on COVID cases, but usually after a surge, more calls with requests for transfer of what we call non-COVID patients. These are regular patients, patients with heart attacks, stroke, and so on. We also receive those calls, and try to facilitate their transfer. Right, and then the supply and equipment was also a challenge. No, of course, we all know about how the world, the scientists of in different parts of the country were developing medications for the treatment of COVID-19. No? So one problem was, of course, the supply. But for me, in particular, what I found especially during surges, na parang simpleng problema pero malaking impact pala niya is the oxygen supply. So like for this last surge, we get a lot of patients needing oxygen supplement. Hindi mo lahat sila kailangan oxygen. So we almost ran out of oxygen supply, yung oxygen tank. So with my talks with other healthcare profession, other parts of the country, mas malala pa yung problema nila. Nauubusan talaga sila ng oxygen tanks, ng oxygen supply. And because of that, tumataas din yung presyo ng mga oxygen tanks. So sometimes in one municipal hospital that I visited, yung mga patients ang kailangang bumili ng oxygen tank nila and umabot sila ng 17,000 pesos. This is in the Cordillera Administrative Region. So imagine na nasa malalayong lugar sila, wala silang oxygen supply. And that was a parang heartbreaking realization for me. Na parang andyan lang yung oxygen, nasa paligid lang natin, and yet itong mga patients nangangailangan, hirap na hirap. So I started looking at different ways we can provide, looking at oxygen, the different devices, like oxygen concentrators, but they can only provide low flow oxygen supply, and then looking at oxygen generators. So yun yung siguro ang baka maging solution for big hospitals, and I know some big hospitals already have oxygen generators, pero PGH doesn't have one yet, right? So yun yung isang I think malaking impact sa on how we treat our patients. And then for the personnel, at first, we needed to improve the level of proficiency in using the different PPEs, or personal protective equipment. So dun pa lang sa donning and doffing, kailangan silang i-retrain or i-train. And of course, the mindset had to be there. We are working in a pandemic. For emergency physicians, we are trained to work in a pandemic mode or in a disaster mode, kumbaga, but not so much for the other specialties. So we had to share protocols and guidelines on how we can efficiently manage a large number of patients needing emergency care. Okay, so one, I think, very critical factor in our COVID response is the personnel, the minds of the personnel. So the Philippine General Hospital Administration conducted a study among the trainees, we call them the residents, training in the different specialties regarding their emotional, mental wellness during this pandemic. So the results just came out a few weeks ago, and there were high levels of burnout, depression, and anxiety among the physicians, junior physicians, or physicians doing their training. So the admin spoke with the different departments and asked them how we can improve the wellness. So for the wellness activities to address these issues. So for our department, we started last year, seeking psychosocial support for our emergency department personnel. And we partnered with PsychServe of UP Diliman. We started this as early as April last year, to provide psychosocial support, because there was so much, not just emotional trauma, but a lot of issues, how we say it, maybe moral, ethical issues, in dealing with large numbers of patients. So just an example of sino ang ipaprioritize mo kung 3 patients dumating, all needing oxygen, and isa na lang yung natitirang ventilator, for example, or isa na lang yung natitirang oxygen tank. So sino ang ipa-prioritize mo? So that causes a lot of emotional distress, moral distress even, kung mamimili ka ng pasyente. No, so we went into a lot of activities. Yung iba naman ginagawa na noon pa. So like other people, no, outside the medical field, pumasok din yung mga emergency department staff sa activities like yan, yung mga plantito dumadami sa department. We had our art class, no, painting class, and the usual food tripping. Kahit sino naman, no, food trip is one way to manage stress, although not a healthy one. Right, so we are focusing on this wellness program, no, to address the issues, the mental health of everybody, no, working in the hospital. Right, so for just what like Dr. Convocar mentioned earlier, no, we need to address the gaps, no, in the healthcare system so that we will be more prepared, no, when not just when another pandemic comes, but with the other disasters and emergencies that will come along, no, being we are in that phase, no, in our climate change situation, no, na we will be dealing with disasters or baka mas worse na mga emergency or disaster situations. So we need to address that, taking a look at our infrastructure, our policies, no, our healthcare system in general, and looking also at our personnel, no, how we can train them, no, to work well, even during disaster situations. Okay, so share ko. Thank you very much for the opportunity.
Thank you, Dr. Lianeta. Now we have time for a few questions. Dr. Concepcion, ma'am. Let's open the floor to our discussion. Anyone would like to start with a question or a comment?
Thank you, Michael. Well, we see Dr. Sarafika's hand raised. And afterwards, I will say something and call on some key PAASE members present here today. Thank you. Al, go ahead.
Thanks, Michelle. This is a question generally for the three of you. Ang dami niyong pangangailangan, nakaka-overwhelmed yung mga, I can see needs for data scientists, for some of what Pauline described as having definitely a database on the cases, what happened to them, where did they go, were they discharged, what type of diseases, what's the even the income class. So I think that's very important, and PAASE maybe can help through Chris Monterola, who's the data science expert at IIM, that's a member of PAASE. On the device side, definitely I'm involved with UP Systems since Giselle was there for the last 7 years on tech transfer, and I'm working with Doc Ewa, who's part of the National Academy with me. We've been discussing on together with Benchit on how else we can accelerate the medical device development. And clearly, Sanipad is just the beginning. Clean Incubate, ESTET, all of these activities are ongoing for the last year and a half already, funded by Jimmy Montoya's PCHRD. But now I'm looking also how foundations like Unilab Foundation can be involved in the fight to increase our healthcare capacity and capability. So if I were to ask you three of maybe three wish list, ano yung pinaka-importante sa inyong tatlo na pwede naming tulungan from either data science or LGU? We also have LGU capability to showcase. With the Mandanas ruling next year, we're also advocating that a lot will be spent on S&T to promote education as well as health as the two areas. Is that something that creating a model like you, Pauline, you're in the South, definitely. And I can see also the need for the education side, which I'm trying to tackle a little bit of the S&T education as well. So if you have your three wish list in terms of how academe and, for lack of a better word, industry or League of Corporate Foundations can help you, what would it be? So at least I know ano yung pangangailangan yung gustong itackle. Maybe ladies first, starting with April, age before beauty. Beauty before age. Ikunin natin si Teddy. Thank you.
Thank you po. Sige, Pauline?
Nahiya naman ako sa age before beauty and beauty before age kasi mukhang panalo ka doon, Ma'am April, sa lahat.
Hindi.
Sige, Ma'am. Good. Thank you so much, sir. Actually, sir, pasensya na, Ma'am Giselle. Pasensya na. Sinadya ko po talagang mahaba yung presentation na yun at umabot talaga dun sa research priorities because I really wanted to have this forum hear the side of the needs po ng emergency medicine. So we've heard it all. But thank you so much. Yung unang-una po sila talaga po siguro is start from the very basic of just having a baseline, just having data. Wala po talaga pa kami noong solid na platform for data gathering because I think that will now become the basis for yun nga, what we cannot measure, we cannot improve. So sa dami-dami po talagang dapat naming i-measure, like say sa services pa lang, the cost of our services. Hindi po namin maipaglaban sa several platforms in government like the Congress or the Senate, the committees and health, if we do not have the data, even specifically po talaga for the costing. With regards din naman po with technology, ang dami-dami pong opportunities sa emergency care also na para po maging narrow yung gap as well at yung disparity sa care, especially po dun sa rurals. Maybe you can also help with that kasi yung hindi po nakakarating sa amin, kahit man lang sana parang enhancing the competencies of the people in our underserved and the less privileged areas po, it would really help po. Sa ngayon po talaga kasi urban-centric and hospital-centric ang emergency care. So if we may also look into the matter of rural emergency care, then it would really also help us a lot. Yun lang muna po. Sana may genie ako na maka-wish ulit ng another one after the third wish. So I'll be holding on to my third wish. Thank you.
Thank you, Pauline. And Michael, if I may, you know, Al Sharafiq and I, we think alike. So my questions are already voiced out by Al, top 3. And I also thought I could identify top 3. Okay, but he also mentioned the Mandana's doctrine and ruling, and that requires that funds be brought down to the LGU level and to the provincial level. At this point, I'd like to suggest to Pauline and also tell you that there may be models of emergency medicine being done better in the provinces. So you are involved in Bacolod. So instead of just identifying the problems, which we often do, we can also show some successes. So that's always my attitude, no? Pakita rin yung mga moderate successes. So before you talk about Bacolod, I'll probably tell you and ask CP David to tell you also about what's happening in Bataan. So in Bataan, you have a whole of province approach led by the governor, Abet Garcia. He's very successful. Poverty incidence is single digit, the lowest in the country. Net migration of population to Bataan, indicating that there are good jobs there. But also his priority program was in health. And he tried to contain or reduce dengue in the province pre-COVID. Okay. Second priority of the governor of Bataan is can we please request our participants to mute because we can hear. So I have to mute some people because we hear the sounds. So his second priority was to do the monitoring of the data. So he's very strong on data based metrics, no, monitoring. And then his father had established tertiary level education system, which evolved to become the Bataan Peninsula State University. Now, PAASE would like to help this very promising province, okay? And we have signed an MOU with them. And so if we wanted to move forward on, emergency medicine, I think I would get CP David to speak up now. And earlier, our leading researcher and head of the Dream Lab for 3D printing and additive manufacturing was here. His name is John Ryan Kokoy Dizon. He's very well trained, including in the lab of one of our PAASE stalwarts, Gobet Advincula. It can design through CAD, through computer-aided design, and manufacture all kinds of little equipment or machinery parts using 3D printing and additive manufacturing. Because you talked about transport pods, you talked about little items that seem to be critical in getting the patient to the hospital. So, who speaks first? Is CP around? Is he able to speak? Or do we get Pauline to tell us about what's good, what's happening that's good in Bacolod? CP, are you there? Okay, so maybe Pauline goes first.
Ma'am, if I may just say also, ang daming taga Bacolod in the chat, in the participants.
All right.
Actually, I'm seeing the chair of the Committee on Research here, Dr. Patrick Tiglao. He's also a visiting consultant in Bacolod, but affiliated with PGH. I have here around 5 residents from Bacolod, so they really can speak up if they wish on the situation on the ground.
Kasi we have to follow models Parang we don't have to start from scratch in every locality. Kaya kung merong nang nag-work, di sana ikwento ninyo, gumawa kayo ng parang summary doon, and then PAASE can see how it can help improve it, no? Pero I tell you, in Bataan and then also in Leyte, we have very good prospects for helping the communities. Why? Because the governors are very supportive. And if you can think of how to get some of that Mandana's budget to help emergency medicine, then wow, it could be presented to the governors. And then the PAASE technical experts can help out. Okay? Then there are many MDs, UP MDs and other MDs in PAASE, including your chancellor, your NIH director, many. Okay? So yes, Pauline, perhaps you can tell us about Bacolod a bit more.
Okay. Not to put everyone on the spot, yung mga taga Bacolod. I'm not saying baka maput on the spot sila. But anyway, Bacolod po is, of course, it's also a young, relatively young population. It's also urban. But the only government hospital in Bacolod City right now is Corazon Locsin. Corazon Locsin is a 400-bed capacity hospital, but in truth, the reality is that, of course, it functions above the hospital capacity. So we're applying for, I think, 1,200 buffer beds, and the services niya extends not just within Bacolod City, but also the entire region. Currently, CLMMRH, or Corazon Locsin Montelibono Memorial Regional Hospital, is the only training institution in the entire Region 6. So even in Iloilo City, wala pa doon. Nandun ang una naming in-establish with the rest of my colleagues here is in Bacolod City. So we already have 2 graduates, and currently we are on our eighth year in the program. So young pa rin po siya. Most of our collaborations are, of course, with the local government unit, but mostly it is just about pre-hospital care as well. Wala pa po kaming community emergency care na ginagawa, but we're trying to also establish stronger networks with our local government unit so that the referral network is strong. We've actually successfully brought down our uncoordinated transfers to less than 10%. Previously, it was the other way. We've had cases that are just brought to the hospital, dropped, and parang ano lang sila, load and go at the scene and then drop, and then they go from the hospital. So it's not coordinated. We all know that those cases that are uncoordinated transfers all have very poor outcomes. So they do not have appropriate care while in transit, and we all know about that spectrum. So we wanted to establish really a strong, uncut, seamless interfacility, because the level 3 hospital or the definitive COVID referral, of course, still is CLMMRH. So yun yung currently something that I'm proud of in our hospital, because we've really brought down that uncoordinated transfers down to less than 10%. Yung iba naman na ginagawa pa lang po namin is we wanted to also have spoke and hub models for some of our definitive care. So yung stroke namin, heart attack, kasi yung mga district hospitals po namin hindi din ganun pa ka-competent. What we do currently is empower them by doing some training. So we do basic emergency care, advanced cardiac life support training. Meron kaming mga arms na we are a referral network, referral center as well for toxicology. The only toxicologist specialist is also an EM specialist, and she's the chair of our department. And currently, siya lang sa buong region nagpa-practice. I mean, in Bacolod City and the province of Negros Occidental. So yun yung mga strengths ng, I think, Corazon Locsin, because of the very strong public health arm niya. And relatively, hindi naman po sa pagmamayabang dito, most of the consultants there are actually PGH graduates and are friends. So parang yung dynamism of the team, very open-minded. Kung merong issues, we really get together. We have currently people there who are currently students of informatics. So we have a colleague also who's doing her master's in health professional education. So one also is doing clinical epidemiology. So with regards education, with regards capacity of the team to really move things forward, make things happen, ang sabi nga namin in one of our parang heart-to-heart conversations is that the capacity is there. It's just that we really, honest to goodness, wala lang talaga kaming pera. Okay. To be very honest.
So,
yun po yun. So that's the profile po of the team and the profile of the hospital.
Oo.
And the population that we serve.
Okay, so matagal na ang medical informatics sa UP Manila.
Opo, ma'am. Mayroon po kaming consultant who's doing her master's right now.
Tapos itong si Dr. Michael T, I believe, involved din dyan. So yan, one area. You don't have to look far. So I think what you need to do is model a community of MDs and emergency care MDs who will work with the rest of the healthcare staff to improve first medical informatics. Second is, how do you now improve, say, these hubs and spokes or this transport problem? You say you are good already in transplant. What about in other areas? So you could, not transplant, sorry, in stroke. Okay, so what about transplant? Other areas. Kung stroke lang, edi stroke lang natin i-showcase, no? And then we can find, scientists and engineers who could help you with your challenges in the transport phase. So you have your hub and spokes model, you have your value chain model. So come up with an infographics, come up with a course, maybe on the general components of emergency care. Let's get Unilab to support us in a micro master's short course on other components, because Unilab Sinovate is PAASE's partner. We have signed an MOU to develop and offer micro masters short courses. And we're going to pair up with Kaohsiung Medical University and other Taiwanese universities to help us in this micro masters short courses. So that's the education part. We have already mentioned the data or medical informatics component, and then we have the transport phase, which seems to be a critical component of your emergency care. So these are just some ideas. Then you have to write maybe a paper. The other thing that we could help you with is how to get perhaps to support from, say, the governor, or from, you already have support from your mayors, but maybe on the governor level. So we're having this interactions with 2 governors in these 2 lead provinces where we are helping. And we have MOUs in Leyte and in Bataan. So that's my input now, Pauline, but I would like to hear also what April and Michael, you have success in PGA. Michael, ano pa? Kayo na, Michael.
Actually, ma'am, gusto kong pagtuunan ng pansin yung sinabi ni Dr. Serafica. No, kasi may sinabi si Dr. Serafica about the TIP engineers who are here. Maybe we can hear from them what they are doing, because this is a good way to connect everyone. No? May mga engineers, nandirito ang ating mga experts, and there are process experts katulad ni Dr. Serafica who will be very good in doing prototype testing in coordination with our experts. So let's hear from our TIP engineers. Sir, please.
Oo, andyan sila, always present at our PAASE Fireside chats and webinars. And they've already been involved in medical devices development. Yes, Dr. Llanes, maybe you can call some of your faculty to speak. We'll see.
Nakita ko dito si Engineer Pestijo.
Giselle, can I say something, Giselle?
Go ahead, sir. Go ahead.
No, I wanted also to comment that it's not also the way of looking at emergency care systems and trying to see what research is there. It can be done the other way around. Let me explain. One of the studies they did in Taiwan was to study the air pollution index. And you know how they studied it? They used an indicator, which is the number of people consulting in the emergency departments for respiratory illnesses. Tapos kinorelate nila yon with the parts per million of the pollution in Taipei. And it's a very interesting correlate, no? So ang thinking ko ganito rin we may be looking at other things, for example, disasters or pandemics or infectious diseases, but we shouldn't be looking at it from the lens of the emergency physician. We look at it from the lens of, let's say, the scientists studying it. For example, air pollution. Air pollution is one thing, and when you have a lot of air pollution, you'll have a lot of people with asthma and hay fever consulting in an emergency department. So kailangan pwedeng baliktad yung look and how the emergency departments are affected by things that are happening in society. So meron din ganung way of looking at the bigger societal picture. And talagang setting is important. If you're going to do collaborative research, kailangan talaga yung ano yung setting, and then both sides have to see their role in that particular context. Yun lang, thank you.
Parang preventive care yan, Ted, di ba? Yung environment, no?
Correct.
Actually, ma'am, that's the concept of One Health with animal.
Yeah,
people,
also One Health, tama.
Environment. No, hindi lang natin nakikita dun sa sinabi ni Sir Ted yung animal component, which is the
O nga, pero Michael, sa PAASE, maganda yung sinabi ni Pauline, knowledge.
But the environment impact, halimbawa, area. Alam ko si Dr. Serafica raised his hand. Yes, sir.
Just wanted to comment for tama yung sinabi ni Ted, there are ongoing studies, Ted, on air quality that we can connect with the height. The example that you used for Taiwan would be a good, again, data from I know LaSalle is in charge of the air quality act monitoring. So they might have the data already and connected with the emergency visits in a particular locality when it rose to a certain level. I think those are good examples on how we correlate environmental and, again, eventually to your appeal of addressing risk reduction and resiliency. I think that's health is a very big component. But I also wanted to appeal from our side of engineers, because when we develop devices, as Michael have insinuated, like the way I've been conversing with Ewang and PGH for the last year and a half, it always starts with a user need. And the user need usually comes from the doctors. So clearly to me, I always like this. We have a program for customer discovery where our engineers always need to talk to the doctors first time, always. But there's also a time wherein that conversation happened already, and now they already have developed a prototype. What I wanted to do is the next step that I wanted the IP to vocalize is that now that they have a device, I've been helping them create a clinical protocol to go field testing. And we've been doing it in Lung Center, and it's not been successful because of the COVID surge. But since I'm in front of 3 exemplary emergency care doctors, do you have a need for such a mechanical ambubag that can be deployed in the transport? It just occurred to me when Pauline was talking about, and then we can create a clinical protocol on how to test it. Is that something that can be an interaction with the group already, since the IP is here? April, maybe can we do that in PGH ASAP?
Yeah, yes sir. We are very open po dun sa mga pag-test ng mga devices, no? So right now, yung isang tinest namin with the ambulance pre-hospital setting is yung yung para siyang monitor na ginagamit natin sa si Ma'am Portia to. Si Ma'am Portia.
Si RX Box.
RX Box, yes po. So it was designed actually, sabi ni Dr. Marcelo, for ambulances, no, for use during transport, pero hindi nila nagawa. Pero so right now, yun yung tinatrial po namin. Paano gagamitin yung RX Box in an ambulance during transport of a patient from one hospital to another.
Yeah, I've been involved with RX Box for 5 years. We need to scale it down for specific use. Kung paanakan, yung toko at saka yung pulse ox at fetal heart rate, good na yun.
Yes, sir.
Pero kung transport for emergency, we only need pulse ox at saka siguro EKG at saka yung respiratory and blood pressure. But I think clearly those are the use cases that I wanted you doctors to tell us. Ito yung use case namin sa emergency care. Ito dapat yung ginawa nyo at saka ito lang yung dapat na presyo kasi ito yung papalitan yung devices namin. So pati yun, kailangan bigay nyo sa amin.
Nakapag-feedback na po kami pero I'll get the report po kung paano
I'll definitely ask Louis Season to get in touch with you, April, on the RX Box team.
Okay po.
But definitely, that's the kind of communication that should be very open, even among one UP in that sense. And I think Michael has been in the middle of this whole part, but he's not the VCR of kaya hindi siya tinatamaan masyado. Si VC Crisostomo ang pinipilit ko palagi. But now Michael's here. Pati sa'yo, Michael, hingi kami ng tulong to get this interaction between UP Diliman and UP. And then, of course, spread it out to the rest of the emergency system.
I've been working with the group of Dr. Caro for a lot of things, like our virtual reality for healthcare. Tapos marami na kami mga yung artificial intelligence na mga ginagawa. Pero nakataas kamay ni Dr. Concepcion, ma'am, Professor Concepcion.
Sabi ko lang, talagang you have to put together these 2 layers. So now all you have 2 specific applications, RX Box and your ventilator. But I also wanted to point out the lead researcher on air pollution is right there in your NIH, Emmanuel Manex Baha. Please get him together with you in this project. That's all I wanted to say at this point. I'm also, just time check, it's now past 10 a.m. So, more.
One last comment, Ma'am Giselle.
Go ahead, sir.
Yeah, another comment is that I think one of the drivers that will push innovation and technology in this field of emergency care and technology is the money part. No, I told you I worked in Malaysia, and one of our research projects was actually a immobilization device for pelvic fractures, and it won an award in a contest in Malaysia. And immediately, UKM's tech transfer people went to us, met with us, started pricing the cost of that device if it were manufactured, distributed, etc. So yung business development part, talagang kaching showed how much money could be earned. And immediately, may mga venture capitalists trying to manufacture it and sell it to the different ambulance units of Malaysia. So I think kailangan din siguro makausap din natin yung people that study the business side of innovative devices. Kasi nga pag hindi yan na paghihintayin mo pa later on, pag may use case scenario ka na, tsaka mo aralin yung cost, magkakaproblema. Kasi nga, we need to study cost-benefit even before we start endeavoring developments of all these devices. Yun lang. Thank you.
Thank you. That's important. Actually, Ted, Secretary Boy de la Peña and I have been thinking of coming up with a fireside chat on one-stop shop, which is what Malaysia has. Pag merong mga innovators, merong mga inventors, they go to this office. And then when there are investors, they know what are the prospective inventions, no? And then the government provides the funding. So, Al, I've been asking us to try to...
Yeah, well, I mean, to answer Teddy's request, indeed, I've been working with the private sector, Ted, Makati Business Club, MAP, PCCI, to convince them to interface with us for the last 7 years. With Stride, I'm part of tech transfer of UP system and all the universities in UP and also De La Salle. It's been very difficult to get them to pony up the money. Let's be frank. So part of our challenge, because of the risk associated with medical devices. If you have a regular, kasi I always have one thing that you remember, don't even remember my name, but if you're developing a device, trim it. The technology has to be focused. The regulatory pathway has to be open. There's some form of intellectual protection, and it has to be manufacturable and market competitive. Yun, trim. That's all kaya ang hirap. Kaya sila ewang, nagkakanda, kamot sa akin, ang hirap naman ito. Kasi lahat kailangan daanan nyo, hindi walang shortcut. So indeed, we're getting to the point wherein we have the technologies, we have the IP, the regulatory is still blocked, but the manufacturing is now in conversations with manufacturers like Perry Ferrer of EMS, IMI. So meron na kaming mga manufacturer potential that has gone through some experience in medical devices. Now the money, the last M, tatlo yun eh. Hindi tatlong matandang madaling mamatay. Market, manufacturability, and the money. How much does it cost? So lahat yan, it's a holistic approach, Ted. We are doing that. And what I'm trying to do now is to ask the League of Corporate Foundations if they can be, since it's less risky money, hindi ko kailangan magpakita ng masyadong ROI, they can maybe fund the first prototype or the first deployment. Maybe that might be a model that will get the big, hopefully the mothership, the big companies that IPADS to eventually invest. But I need your help, guys. I need the doctors to say, we need this. People are dying. It can help and can save a lot of lives. And then we develop it together as engineers and doctors. Then we clinically test it. We have a regulatory approval and we manufacture it. Hopefully it can be done in less than 3 years because that's a typical time frame from the beginning of the project and the concept all the way down to completion and marketing. Ganun katagal yun. Unfortunately, there's no shortcut. So let's start now. Today, it begins for emergency care. How's that?
Yeah,
thank you.
We have been waiting for the longest time. The problem in the country is the business sector is not exposed or predisposed to invest at an early stage of development, whereas other countries have such investors. So this one-stop shop in Malaysia is open to foreign investors. Supposedly, our country is into FDIs. So bakit? Because the scientific or engineering literacy of the business sector in our country is relatively low, and they have alternatives for much better ROI, sadly, no? So anyways, I think it's important to work on this system, and Secretary Boy says that we should invite people in DTI to talk about this one-stop shop that he had talked about already before. So I think now we're coming to the end of our fireside chat, but there might be somebody from TIP who wants to speak. Yes, any of our engineers, our partners from TIP would like to speak at this point?
Yeah.
Yes,
Good morning.
great.
Good morning.
That's
Good
great.
morning. So I'm with the graduate program, so I had to call on our developers from TAP to make the report. Now, so this is the information I got from them. We already had funding for the ventilator project. We have our engineers have already developed the prototype. It has already undergone the extensive technical testing required for the device. So we've had certification done by our partner companies. At the same time, we have also passed the certification of the DOST EPDC. Currently, in preparation for the clinical investigation, we are requesting for ethical clearance from the Lung Center of the Philippines.
Fantastic. Fantastic, Ruji. Thank you so much.
Congratulations.
Congrats.
Ituloy na natin, Ruji, beyond Lung Center for the COVID patients and Pulmo. Let's try to use the another clinical protocol together with April na for ambulance utilization. Para hindi na yung nurse ang nagpipiga dahil makina na kayo. So I don't know how many prototypes sila have, but I think we may be able to have that one as a quicker clinical trial. Pagod na ako I've been helping you guys for 6 months trying to get that protocol approved in the IRB in Lung Center. Na-COVID tayong lahat But hopefully this can be another alternative for clinical use already in the emergency setting. So I'll talk to May about it also, given that you already are here in present. Thank you.
On that high note, Al, maybe Michael can now close this chat. Thank you so much, April, Ted, and Pauline, and Ruji, and everyone who participated in this discussion. Kahit na merong konting one bright star lang na kita tayo ngayon sa Fireside Chat, okay na yan. Al, we never give up, di ba? Di ba? Sige, Michael, please, end our chat.
Yes, Professor Concepcion and the PAASE member, thank you for this opportunity to co-host this session. Now, I learned a lot, and I appreciate the emergency medicine more after hearing what Dr. Herbosa told us about his efforts to develop emergency medicine in the Philippines and how it is spread among his students, some of whom are also my colleagues in PGH, like Pauline and my classmate, April. So now, having also interacted with engineers, we can probably start working or continue working on innovations that will add value to our way of caring for our patients. So thank you very much, and I really appreciate how PAASE connects many or multidisciplinary, multi-professionals, and provide us with a conversation platform. So like what I did, I already gave through chat Sir Gonzalo Serafica my number so we can start innovation in the future. So thank you very much, and good morning to all.
Thank you. Thank you from
Thank you
PAASE.
po. Thank you po.
Mga heroes natin.
Thank you.
Heroes natin. Oo, maraming salamat sa inyo. Kung paano
Stay in touch, guys. Stay in touch.
Kahit konti lang attend ng ating fireside chat, basta yung critical people na
Thank you,
andyan.
thank you.
Okay.
Ed,
Thank you, Al. Thank you.
Ed, ikaw ang general namin. Kailangan ka namin.
Oo. Sure.
Harap ka.
Oo.
Husay ang
Thank you.
Thank you.
Oh, we will end now, Al. We will end now.
Yeah, thanks, Giselle. Good one.
Michael, thank you so much.
Thanks, Michael. I'll chat with you soon.
April, Ruchi, thank you so much. Jimon is here, our teacher.
Ma'am.
With chemistry, she's here. Jimon is here. Okay. Bye-bye.